Have you ever wondered what your blood count can actually reveal about your health? The complete blood count, or CBC, is one of the most common tests your doctor orders, but how accurate is it really? In just a few minutes, we'll uncover the secrets behind the essential test, why your numbers might fluctuate from one visit to the next, and how your lifestyle, things like diet and exercise, could be skewing the results. Whether you're an athlete wondering how exercise might affect your numbers, or just curious about what those numbers mean, this episode will give you insights you need to truly understand your CBC. Stay tuned. What you learn today could change the way you look at your blood test forever. Let's get started. So let's dive right into our introduction to the CBC. So what is a CBC? First of all, it's called the complete blood count. I'm going to call it the CBC because that's way easier. It's a widely used lab test that measures various components in the blood, providing information about your red blood cells, white blood cells, platelets, things like that. And the purpose, it can be used for a bunch of different things. Used for routine checkups for some people. We'll talk about whether that's appropriate or not. We'll talk about how we can diagnose things with it, and monitoring of various diseases. And the test is a simple blood test. You get it drawn. It's using an automated machine that counts and evaluates the blood cells. And let's talk about the importance of it in clinical practice, right? We've heard about this. This is probably one of the most common ones we hear about. It is commonly ordered in primary care for screening and diagnostic purposes. So whether that's right or wrong, not necessarily the point right here, but it's used all the time. Some people get them for their yearly labs, but it plays a crucial role in detecting things like anemias, infections, or hematologic diseases, and provides a broad overview on some health markers, which can often be the first sign of something going on and can lead to other diagnostic workups, and can also be used to help monitor side effects of medication. So this is one you will see quite frequently. And do I think everyone needs to get one all the time? No, absolutely not. That is not indicated, but quite frequently people are getting this. It's a common one. Next, let's dive into the components of the CBC. You can see right here, this is a lab printout of what a CBC typically looks like. If you are not watching the video version, I'm going to walk through what it typically looks like. And you can see this is just the overall result here. So right on the left side, we have the test description talking about things like hemoglobin, and then talks about leukocytes, or our white blood cells, the different types of white blood cells, how many there are of the white blood cells. Then there's talk about red cells, different characteristics of the red blood cells, and the platelets. So that's the general components. And then usually we have some sort of result, meaning, hey, this is what your labs show, this specific number, and there's a reference range. So this reference range here is typically what is quote unquote normal, right? So this is a quote unquote normal based off of various things. But at the end of the day, there are multiple reference ranges. In terms of reference ranges will depend based on the location you get your labs from, its reference population. So one population in one part of the world might be very different, and then demographics as well. They're generally similar, but may have some slight differences. You'll see if you look at one website versus another, there might be some reference ranges. It shouldn't be insanely different, but you might see some differences as well. And you should note that some of the reference ranges have recently been corrected to try to be more inclusive, as lots of previous databases predominantly came from white participants. And so we're trying to find a more diverse one to encompass all of that. But that being said, as I explained in the first episode, there's lots of variance to labs, right? So it's hard to definitively have a set in stone reference range. That accounts for all this variability as well. But in general, the reference range should be listed on any sort of test. It'll kind of give you that saying, hey, this is the reference range that we use. And more or less, those are generally a good place to start when interpreting labs. And I'm going to walk through step by step here, kind of going through this CBC count, and it's going to be helpful to say, this is what the CBC shows, and we're going to go through that step by step. So first and foremost, looking at red blood cells, so RBCs, this measures the number of red blood cells in a given volume of blood. So it's counting how many. And we care about red cells because they carry oxygen. So specifically, it's really important for endurance athletes, right? So the more red blood cells you have, that's better. The normal range, once again, varies by age, sex, and altitude. And on top of that, males are a little bit different from females. You can see on the screen here. It's usually about, for males, about 4.3 to 5.6, and females about 3.9 to 5.13. Once again, not set in stone. And the reason we care is because if you have a high red blood cell count, something called polycythemia, indicates there may be some dehydration or serious things like heart disease, lung disease. And if you have a low red blood cell count, that could suggest anemia. And so on top of that, EPO, there's this hormone called EPO, or erythropoietin, that is created by the kidneys that essentially creates and helps make these red blood cells. And this is a huge molecule that they call in doping, like Tour de France. Everyone's on EPO, right? Because it made more red blood cells. And if you had more red blood cells, you can carry more oxygen, and great for endurance athletes. So that's from an athletic side of things. You might have heard EPO and red blood cells. Those are really important. Moving on to hemoglobin. Hemoglobin is probably the most common one everyone talks about. This reflects the amount of hemoglobin in your blood. And you might be like, well, what is hemoglobin? Hemoglobin is the protein that is found inside of red blood cells that actually carries oxygen. So obviously very important because it's carrying oxygen. And typically for this, ranges are around 13.8 to 17.2 for men and about 12.1 to 15 for women. And overall, a low hemoglobin can result from things like nutritional deficiencies, chronic diseases, bone marrow disorders, or actually acute blood loss and things like a GI bleed. So if someone has a low hemoglobin, it can be a bunch of different reasons. We want want to figure out, hey, is this from a short-term or long-term type of problem? Next, moving on to hematocrit. Hematocrit represents the proportion of blood volume occupied by the red blood cells. So it is the proportion of blood volume occupied by the red blood cells. So the volume of RBCs compared to the whole blood. Normal ranges range from about 40 to 54 in men and 36 to 48 for women. This is used to diagnose and monitor anemia as well. Also things like the polycythemia, having too much red blood cells, and then also hydration status. And we look for, like I said, when patients are on testosterone, we also look at the hematocrit, right? Because it can be greatly elevated. If it's too high, that can indicate that we're at a risk for things like clotting. Next, getting away from our red blood cells, we're going to talk about our white blood cells here, or WBC counts. This measures the number of white blood cells in a certain volume, which are key players in the immune response. Normal range is about 4 to 11, you'll see on readout. And an elevation in this can indicate an infection, inflammation, or things like leukemia. And whereas low white blood cell counts may also suggest some bone marrow suppression, autoimmune disease, or other severe infections. And so once again, any abnormality in your white blood cell count, not something we usually mess with because it can be indicators of either things like an infection or cancer. And so typically we let the white blood cells we pay attention to those. And obviously there's a normal range and people have variability in and of themselves. But if someone has a grossly elevated white blood cell, we usually don't just say, oh, that's no problem. That's something we care about for sure. Then moving on to the platelet count. Platelets are essential for blood clotting, right? They kind of start this whole clotting process. Normal range is about 150,000 to 450,000. And you can have either too much or too little. If you have too little, it's called thrombocytopenia, can cause bleeding, meaning you don't clot very well. Or if you have the opposite end, we have thrombocytosis, or too many platelets, can increase your risk of clotting. So it's finding that right balance. We want to be right in the middle. And next, we're going to look at some additional markers of red blood cells, kind of here, the mean corpuscular volume, or MCV. This measures the average size of red blood cells. So the MCV is used to classify anemias as either microcytic, normalcytic, or macrocytic. Normal range about 80 to 100. And a low MCV often suggests an iron deficiency anemia, whereas a high MCV indicates things like potentially B12 or folate deficiency. Next, going hand in hand with MCV, we have MCH and MCHC, which MCH is the mean corpuscular hemoglobin and MCHC is mean corpuscular hemoglobin concentration. These are kind of getting in the weeds a little bit, but you'll see them on your CBC, so I wanted to go through them. MCH indicates the average amount of hemoglobin per red blood cell, while MCHC reflects the concentration of hemoglobin in a given volume of red blood cells. So MCH and MCHC are used in diagnosing and classifying different anemias. And if you have like a low MCH and MCHC, often seen in iron deficiency, whereas if you have a high MCH, you're often seeing something like macrocytic anemia. And I know you're saying like, what is macrocytic versus microcytic anemia? Essentially, that's just the size we're seeing of these things, right? If we're saying, hey, the red blood cells are way smaller when we have a low MCH, then we think of a microcytic, whereas when they're bigger, we think about some sort of macrocytic anemia. And now let's talk about some clinical significance of CBC components, right? So when we're interpreting these, they are very important and they can help diagnose, once again, things like iron deficiency anemia, where we're having maybe showing low red blood cells, low hemoglobin, hematocrit, and a microcytic. Also, it can show if we have a high white blood cell count, we worry about some sort of infection, and depends on if it's bacterial or viral based on the lines, and we'll talk about those as well. And platelets are also really important for monitoring clotting disorders. And the really most important thing is we have to evaluate these in the clinical context of the patient, right? We talked about this in episode 1, is that when you blast labs and then you just look at them, you're like, oh, I don't know what to make of this. If you got a normal person who is having no symptoms whatsoever, got their labs and they're just a little off, do they clinically mean something? I don't know. That's going to be hard to do on yourself and understand on your own without working through it. But there's multiple reasons why we want to look at it. For example, let's say someone has fatigue and they're kind of white, which we call pallor, and they may have anemia, and that's what we worry about with the CBC. Or let's say someone has an elevated white blood cell count and symptoms of an infection like fevers or chills. Well, then that'd be very helpful to know. Or someone having easy bruising or bleeding, that can be linked to low platelet counts. And so once again, it's really, really important that when you're going through all this stuff, that you have a clinical picture and a reason for ordering these, right? Like this is not one that I recommend you just say, hey, let's just order this just to see what's going on. A lot of times there's a lot of components, as you see here, a ton of components of the CBC, and there's lots and lots of ways to have just slight abnormalities. Then you have to go explain every one, might lead to additional testing. And so this is just something that's usually not used for just straight up screening. You usually do it when someone has symptoms. But on top of that, now I want to go dive a little bit deeper here. So if you break down this page here, you can see that there is a differential, what's called here. So we were looking at things like neutrophils, lymphocytes, eosinophils, monocytes, basophils. These are different types of white blood cells. And then we have even more in times that we talk about the absolute count, meaning how many there are of those. And so the differential is different from just the regular CBC. The differential provides the percentages of different types of white blood cells. And it either can be presented as a percentage or as an absolute count. And the types of white blood cells, as I mentioned real quickly, they are neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And the differential can be helpful for diagnosing infections, inflammatory conditions, hematologic diseases, and allergic reactions. And now each one kind of signifies something different. We're going to walk through what an elevation or a change in one of those might mean. So let's start with neutrophils. Neutrophils are the most abundant type of white blood cell, making about 40 to 70% of the total count. And they are usually the first responders to bacterial infections and play a critical role in acute inflammation as well. So if someone comes in and says have elevated white blood count with neutrophil predominance, meaning, hey, there's a white blood cell count is elevated in total, but then proportionally it's more neutrophils, then you start to worry about a bacterial type infection. You also can see this with stress, trauma, or inflammation. But if someone's coming in they're looking sick and they have a neutrophilia, I'm not super excited about that. And can be present also in chronic conditions, things like different sorts of leukemias as well. But overall, if it's elevated, I'm a little worried about that. And if you have a low number or low neutrophil count or neutropenia, then you can have maybe something like bone marrow suppression, either things from like chemotherapy, radiation. You can have severe infections that cause just a profound decrease in that as well. Like sepsis, sometimes you don't get a mounting response, or anaplastic anemia, kind of that, all lines are down, or you can have autoimmune conditions. But at the end of the day, neutrophils typically are meaning bacterial is like what I kind of tie it with. Man, if they're elevated, I think what a bacterial infection. Whereas moving on to lymphocytes are the next most popular, constitute about 20-40% of white blood cell count, and are primarily involved in the adaptive immune response, and specifically virals. There's different types of them. There's T cells, B cells, and natural killer cells. These are the part of your immune system that go and attach onto things. If we have lymphocytes that are elevated, we see that with viral infections quite frequently. Things like Epstein-Barr, CMV, those things like mono is a lot of times a big viral you'll see, and other autoimmune disease. And then low lymphocyte, you can have, may see that in HIV or AIDS. You can have that occasionally when you're taking on steroids or other things like malnutrition. But once again, if you think lymphocytes elevated in a viral infection, that's typically what I think about. The way I kind of think about this is if someone comes in and we get a CBC and they're feeling sick and it's elevated, then you can kind of look at, hey, are neutrophils elevated? If they are, I think maybe possibly bacterial. And if lymphocytes are elevated, then maybe a little more viral. It's not that easy. It's not slam dunk there, but that's like general heuristic that I think about. Then moving over to monocytes. Monocytes make about 2 to 8% of the total white blood cell count and differentiate into these macrophages and dendritic cells in tissues. And they're involved in phagocytosis of pathogens, dead cells, other debris. Essentially, they're the scavengers. They go around there and then they just gobble stuff up and then present it to different T cells so your body can take care of it. Also, macrophages play a role in atherosclerosis as well. And if we have elevated monocytes or monocytosis, typically think about some sort of chronic infection like TB, other inflammatory conditions, and certain malignancies. And then if it's low, then it's pretty rare. We're kind of talking about hematologic circles here, but maybe think about bone marrow suppression or other things. Moving on to eosinophils, then they're about 1 to 4% of total white blood cell count and are primarily involved in the response for parasitic infections and allergic reactions. So they release enzymes and toxic proteins to combat multicellular parasites and play a key role in hypersensitivity reactions, which is kind of like when you get everything, allergies, essentially what it is, and can be seen in asthma and eosinophilic esophagitis. If you have lots of eosinophils, you can see that in a parasitic infection. Also might see it in allergic diseases like asthma, hay fever. Those are the big things I think about. And if you have a low eosinophil count, that is usually not very relevant because it can be all the way down to 1%. So usually you don't see that. So not as common. But eosinophils, I think about allergy and parasites are kind of the big things. And then basophils as well. These are the least common, less than 1% of the total count. They are involved in inflammatory responses, particularly also allergies, again, and asthma. Basophils can release something called histamine and other mediators that contribute to this inflammation. And a high basophil count, it's rare, but associated with chronic myeloproliferative disorders, potential leukemias, allergic reactions, maybe hypothyroidism. And then low basophil, once again, not a lot of clinical significance. And so that's a lot going on there. I understand that, but kind of breaking it down, you think neutrophils, right? Bacteria, think about lymphocytes with overall viruses. When you then move down to monocytes, you're thinking about, are there any sort of pathogens they're talking about? Essentially, think about chronic infections. Eosinophils, think about like allergy or parasites, and then basophils also kind of general allergy. And once again, that's a 30,000 foot view. There's a reason hematology oncology is its own specialty because it's way more complicated than that, but that's something to think about. And next, I just want to talk about absolute versus relative counts on the CBC. If you see here in the picture, there's kind of these counts. We have differential and counts. The absolute, the differential can be reported as once either a percentage, which is the relative count, or an absolute count. And that's the total number of each type of white blood cell in the blood. per that sample of blood, I should say. And the absolute counts are often more clinically relevant because they account for total white blood cell count, providing kind of a clearer picture of any abnormalities. For an example, a relative increase in lymphocytes or lymphocytosis might not indicate a true increase in lymphocytes if the total white blood cell count is low. And so we say, oh, like we saw it just a little bit, but overall the white blood cells aren't elevated, so it might just be kind of, a reactive state of that. But overall, sometimes that can be very helpful for understanding immune responses and what your body is doing for mounting these responses. That is not something you need to worry about necessarily interpreting. That if we're getting sick and we're worrying about differentials and relative versus absolute, you definitely should be under the counsel of a physician, but that's just something to think about as well. And the reason why the differential can be helpful overall is because it may help distinguish between bacterial and viral infections, identifying allergic reactions, and detecting hematologic disorders. And once again, let's just say a patient comes in with a fever and elevated neutrophils, they may have a bacterial infection, while someone with a fever and lymphocytosis may be more viral. And as I mentioned before, it's not that easy, but it can be helpful for lots of reasons, kind of narrowing things down. And so I'm just giving you the 30,000 foot view of what the differential is, but you'll see it on your CBC. So I want to mention it, that we look at this to kind of say, hey, what does this mean? And I will tell you, this is probably the area of when you get a CBC, you will have the most abnormalities. Most of the time, most people have a normal hemoglobin and red blood cell count and all that stuff. But like this, when you get the differential, this will be the one that will have, oh, like my basophils were just a little bit here, or my neutrophils were just a little bit up here. And this is why it's so important to work with someone when you're interpreting labs, is because how do you determine what's clinically important? Honestly, it's lots and lots of reps and experience and understanding the whole clinical picture. We talk about pretest probability in the first one. We talk about having a clinical understanding of the patient. So it's much more than just like, oh, I have this number, it's an abnormality. No, there's lots of nuance there. And just for the sheer number of tests in a CBC, when you have this many numbers of tests, like things are going to be off. And so it's important to understand, hey, understand where we're going, but the differential is probably where we're going to have the most, issues in there. Next, moving on to common diseases diagnosed or monitored with the CBC. Anemia is the big one, right? You think about when we're not talking about necessarily illnesses, iron deficiency anemia. This can be caused by either chronic blood loss, where you have like GI losses, something like that, or other reasons you can have it as well. Obviously, not enough intake of iron, all those things. But finding on the CBC, you'll typically have a low red count, low hemoglobin and hematocrit, and then something that microcytic MCV, or that lower MCV. Whereas if you have something like a hemolytic anemia, this is where your red blood cells are kind of getting cut. And this is the red blood cells getting sliced open. You might have a high reticulocyte count, which reticulocytes are typically not on CBC always, but that is an indicator of how many red blood cells you're making. Like, hey, if your reticulocyte count is elevated, that means you're making more of them because you're trying to replace them. You may also see a low RBC and then something called elevated bilirubin, which we'll talk later about in different podcasts. And then you might have some other things, other anemias, more rare aplastic anemias, where we might see all lines down. That's not that important. Also, we're monitoring infectious diseases, right? Once again, for our bacteria, we just harped on that, looking at the neutrophils, viral infections, looking at lymphocytes specifically, and all those are reasons why we could monitor you. When you're hospitalized, you go to the hospital and you have pneumonia, we usually get a CBC every day to kind of see it tracking, maybe every other day, to make sure it's going down and we're improving there. Also, we can use this to monitor for hematologic malignancies, things like leukemia, lymphomas, things that, once again, you should not be managing on your own. And if you are, you need to be talking with someone. And then on top of that, we also have things like thrombocytopenia and thrombocytosis. And thrombocytopenia, when we have things down, we have things called ITP, or immune thrombocytic purpura. You may have aplastic anemia, heparin-induced thrombocytopenia. All these, long story short, are reasons to have decreased platelets, which once again increases your risk of bleeding. So whatever you want to take from this is thrombocytopenia. If you have low platelets, high risk of bleeding. On the other side, if you have thrombocytosis, where you have elevated ones, that is an increased risk of potentially clotting. So that's really the 1,000-foot view of how we're using these to monitor and track symptoms and diseases. This is the most common ways of doing them. There's other ways as well. But I did want to mention the limitations of the CBC, and some of the limitations include that you can't really diagnose specific conditions alone with this. It's kind of a screening tool and can't definitively diagnose conditions like iron deficiency anemia without other confirmatory tests, right? And it's really important to have clinical context, like I mentioned. CBC results should be interpreted alongside a patient's history, their symptoms, and other diagnostic texts under the guidance of a professional. And like I said, there will be a lot of noise in a CBC usually. Most of it's not clinically significant. This is where you need someone to guide you, right? And there's also a lot of potential for misinterpretation here. Factors like age, gender, ethnicity can influence normal ranges. Also, if you had a recent illness or on certain medications, the CBC results can be skewed. For example, if you're taking steroids, that will cause an elevated leukocytosis or white blood cell counts to be elevated. That's like super common. You see someone who had COPD exacerbation and they got steroids in the hospital, then you get a CBC count and all of a sudden the white blood counts through the roof. And this is like, oh, is this an infection? You say, no, this is very known and well known with steroids, but something to have to consider. And also there's external factors that may impact CBCs, meaning dehydration. That may falsely elevate red blood cell counts and hematocrit. Acute stress, infections, or chronic conditions may also elevate white blood cells or platelet counts. And also there's definitely variation, right? So there's studies that show normal biologic variability can lead to fluctuations in hemoglobin about 0.5 to 1 units, and in platelet can be about 10 to 15% from one test to another. So this is why a lot of times I take this kind of sounds weird, but I take the approach of if something's abnormal, that's not like crazy drastically, like I'm worried right now. But if it's a little off, I'll usually repeat the lab. And even if it is crazy off, I'll usually repeat the lab to make sure it's not an abnormality, just because there can be variability that we see day to day. And so those are kind of limitations. Next, because this is the Building Lifelong Athletes podcast, I want to talk about the impact of nutrition, exercise, and being an athlete on the CBC. Overall, there's definitely nutritional factors that can play a role. As we talked about before, different anemias may be related to nutrition. Specifically, iron, vitamin B12, and folate are big things, and they can affect the red blood cell count, hemoglobin, and the MCV. If you don't get enough iron, we mentioned that before, can lead to iron deficiency anemia, which shows with a low red blood cell count, low hemoglobin, and low MCV. Whereas if you get not enough folate or B12, it may lead to that low hemoglobin again, but with a high MCV. So that can happen. And on top of that, you can also have thrombocytopenia or a decreased amount of platelets with low folate. Moving on to exercise. Exercise will affect your CBC depending if it's acute or chronic. Whereas acute exercise may transiently, meaning come and go, may increase white blood cell count and platelets due to a stress response, and that's normal, right? So we've mentioned before, you can have elevations in white blood cells and platelets due to a stress response, and that's what exercise is, right? Exercise is a stress to your body, but it's a good thing. Whereas if you have a chronic endurance training program, that can kind of lead to lower resting white blood cells and RBCs, known as sports anemia. We'll talk about that more in one second. On the other hand, if you're working out and sweating a lot, you might have something called hemoconcentration, and your plasma volume, so the amount of fluid inside your blood, may actually change with exercise because you're sweating things off. So when you sweat and lose plasma volume, you don't lose things like hemoglobin and white blood cells, right? Those stay in there. So therefore, it appears like you have a higher hemoglobin or something like that. We call that hemoconcentration. So there's a chance that if any of your lines, your red blood cell or hemoglobin or white blood cells are elevated, or more specifically, if all of them are elevated, that might be hemoconcentration. And then if you hydrate, that usually improves. And we see that quite frequently in patients coming to the ER, right? They're very dehydrated. All their lines are elevated. And we think that's hemoconcentrated. Give them fluids and it comes down. So that's the question. Then you're like, oh gosh, if it comes down, are they losing blood or whatnot? And usually no, if you understand the normal physiology, that they need that and it will naturally come down. And it does work conversely though. If you drink too much water, then the cell lines can all go down, which is hemodilution. And then if you kind of withhold some fluids for a little bit, usually it comes back to normal. But those are all things to consider. Next, let's talk about being an athlete. Things to think about with our athletes, specifically here, endurance athletes. They a lot of times have lower resting hemoglobin and hematocrit levels, which might be misinterpreted as anemia in non-athletic populations, right? So if you had someone who doesn't exercise and you had a low hemoglobin and hematocrit, that would worry us a lot. Maybe it depends on the level of it is, but we'd worry about that. Whereas if you're an athlete, it just gives us more things to think about. I still will think about it and worry about it, but I need to consider that, understand that may be a normal variant. So what is athletes anemia or sports anemia? And in athletes anemia, or AKA sports anemia, it's a condition commonly observed in endurance athletes, particularly those involved in long distance running, cycling, or swimming. And it's characterized by lower than normal hemoglobin concentration and hematocrit levels in the blood, which may be mistaken for true anemia. Occasionally, kind of once again depends on things, but it is generally a benign condition. We think about it to be benign, and we think that it appears with regular endurance training and it's not pathological. And why do we think this? Well, there's a couple mechanisms for why we think this. First, you can have plasma volume expansion when you are a long-term athlete. So the primary mechanism we think for this is probably that increase in plasma volume, which dilutes out the concentration of red blood cells, leading to lower hemoglobin and hematocrit levels. And this expanded plasma volume helps improve cardiovascular efficiency during exercise. So this is an adaptation from an endurance athlete's body saying, hey, I'm going to hang on to more fluid in my bloodstream so I can help circulate my blood more efficiently, and it's going to lead to improved cardiovascular efficiency. So that is an adaptation that is normal, and that's not pathologic. Sometimes you may see anemia though from an iron deficiency. So if they do have an anemia, it could be iron deficiency. We have to think about that because they are an increased risk of iron losses through sweat, urine, GI, or potentially hemolysis. So we think athletes' anemia is potentially benign if it's just through plasma expansion or other mechanisms. But if it's iron deficiency, then that wouldn't necessarily be benign. We'd want to treat that. And finally, they may have some hemodilution, meaning dilution of the red blood cells due to increased plasma volume. Like we mentioned, the plasma volume extension. That's also beneficial because it reduces blood viscosity, improving oxygen delivery throughout the rest of the body. And so these are normal adaptations, specifically expanding the plasma volume, and might see some hemodilution. It's just trying to get that blood to go faster and faster and faster to kind of improve the output. So we think about that, but we also have to remember about iron deficiency as well. And the clinical implications of this typically doesn't require treatment, right? It's an adaptive response rather than a true deficiency. But it's crucial to differentiate athletes' anemia from a true anemia, right? Which requires more investigation, treatment, and particularly if it's iron deficiency, we're going to have to treat that. And monitoring this should focus on symptoms as like fatigue or poor performance, as they can occur alongside with low hemoglobin levels. So if someone's saying, hey, I'm at the peak performance of my life, never been better, feel fantastic, and you find this, and you're like, okay, what do I make of this? Probably not anything. Whereas some on the other side of things says, hey, I'm fatigued, I feel terrible, I've noticed like my eyes are getting whiter, my skin's getting whiter, I just feel terrible, and then they have anemia, and they're an endurance athlete, I wouldn't say, oh, that's just sports anemia. Then I think, hey, that might be real. And so once again, have to correlate with someone, how they're doing with their training, all those sorts of things. And overall here, I'm just going to bring it home with the conclusions is that, I think the CBC is a versatile and essential tool in primary care. Use it all the time. I wouldn't say it's part of our typical screening labs though. That's not what we recommend just because it oftentimes doesn't pan out that we need to do that. Obviously, as I mentioned in the first time, talk with your doctor, figure out what works for you. But typically this is not part of our quote normal labs. It's going to tell you lots of important things about things like your white blood cell count, hemoglobin, platelets, and all those things. And I encourage people to use the CBC results in conjunction with a comprehensive assessment of a patient history, their physical exam, and other diagnostic tools. At the end of the day, nothing really matters without clinical context. There's certain things that maybe matter more or whatnot, but if you don't have the clinical context, it's really, really hard to interpret labs. And that's kind of the foot stomp you're going to hear in all these different podcast episodes is that a clinical picture is very important. But I hope this was helpful for you understanding what the CBC tests for and how we think about it. And this does conclude the podcast, but thanks so much for stopping by. I do appreciate it. If you found this helpful, it'd mean the world to me if you left a 5-star review on your podcast platform of choice, or if you shared it with a friend who you think might enjoy it. And if you never want to miss a piece of content, consider signing up for my mailing list, which it's in the description below. I'll just send out the content I release during the week just to make sure you don't miss it. And I promise I'll never spam you because I hate spam very much. And that's it for today though. Now get off your phone, go be active, have a great rest of your day. We'll see you next time.